point. Especially because I've got a personal accountability on this as well as a professional one. And I'm not convinced that our systems of risk assessment, I don't mean in the detailed in the departments, but our overall risk assessment on the very many areas of health and safety legislation is sophisticated enough to give us that. So should I be worried about hand-arm vibration? Should I be worried about control of contractor? Should I be worried about asbestos or about stress? So that we can see it all in the round. I think the guys have been a bit limited over that last year to do very much detailed work. But as George said, we've got a new head of health and safety, and I'm confident that she's got a programme of work planned, and in she's done this before, that gives us that comprehensive overview. So that's the stuff that will then get into the strategic plan. On things like violence and aggression, there will be some things that are almost always reported because we train people to report. So slips, trips and falls. I don't know what Angela thinks about this, but when I trained as a nurse, it was like, oh, you've got to report that. So there will be some things that are reported more, which is why balancing with risk assessment is really, proactive risk assessment is really important. On violence and aggression, some of that will be the behaviour of people. Some of that will be the effects of an illness. And the aggression that comes from that. So they need different mechanisms, but I think that is an area for us to get underneath a lot more. On the policy, Pam was smiling at me because we've had lots of discussions about how many policies we've got, whether people shoehorn every single procedure into a policy, and whether we can strip them back a bit. So this is a great candidate for that. And I think that helps because one of the challenges is seeing the wood from the trees. So that's what we really need to do, is to strip out some of this. And Claire, just in the last 5 months, I think I've been chairing this health and safety group for the last 6 months or so, getting a good sense of actually people are quite committed to this agenda. So that gives me a sense of confidence. Each service does their report, does their learning. So I think there is a base to work from. My sense is how we enable people to work on the right. It comes to that sensible approach to health. Sensible approach. That would be quite a good thing. But I think to the risk, and we can only be proportionate to the risk when we really know what the risks are. Yeah. So I think that's really what is meant by that. Yeah. But yeah, this is definitely work in progress.
And there's a tremendous amount of work in here. It covers a lot of things, and it's quite far-reaching. And one thing that struck me was I'm sure people in the health board would want to know what they are accountable for.
Yeah,
that's one of the difficulties. You can't be accountable for everything, but that right and the balance is important. Karen, and then we will finish on this item.
Just two things. Just from the report, and it might be that this is something that we've got more in development, but we're not looking at near misses in the report. And obviously, from a risk management perspective, understanding near misses and what they might lead to. So hopefully we'll be able to build on that for next year. And then just to sort of come in from the audit committee's perspective, obviously,
because I'd asked for them to have a look at this, to give us that fresh eyes perspective, so they shoehorned it into their programme.
So great. Pam hapus I gymeradwyo a policy.
So you're all happy to approve the policy and the annual report? You all happy to approve? Great, thank you very much. Thank you very much for your work, in particular George for presenting the paper as well for us today. Thank you very much, George. So on we go to the next item, And I think we've set out the next item thanks to Pam for her guidance. We've got sections that tie up the committee chair meetings with the topic meetings. So the first one that we have is the chair's assurance report. And then the next item is around culture and engagement and leadership. So we've received copies of the chair's report. David, do you have anything to add to us? Or anything you'd like to draw attention to from that report? Yeah, well, thank you. So that everyone's had an opportunity to read through the report. But I think it's also important to note how this committee is developing. It is, of course, a new committee, and there will be a point where I will have to stop saying that it's a new committee. But it is a development, and I think the item on health and safety now shows that there is still work to be done. But I think we are making very good progress as a committee. We've got a session in our next meeting in a couple of weeks' time. We've also got a development session that's been put together. And I think that the work, in particular, the work around culture and on the values and behaviours is very important. Because it does touch on everyone in the health board. No matter what your role is within the health board, if you're a member of the senior management team or anywhere else. Values and culture is very important, and it's important that we get it right. And I very much hope that we're on the right path. And I'm glad to see that there are items coming up now to touch on that as well. People are quite welcome to ask questions or make comments as suitable. So are we happy to note that report from the chair? Everybody happy? We'll move on, therefore, to the associated item around engagement, leadership, and I'll turn to Carol for this item.
Great, thank you. I'll make a start and then I'll just pass over to George for additional comments. So this is progress reports following the 9 areas of intent that the board approved back in a year ago now, September 23. That year's gone quickly. And really is trying to demonstrate the range of work that's been taking place. Of course, board members will know because you participated in much of that, the work with Michael West, for example, and your presence at some of the leadership conferences that we've had. And more latterly, our focus on the work around values and behaviours, which at this stage we're midway through that, a little bit more than midway, and intend to look to do a second stage of engagement on that. I think that's a very serious piece of work for us as a board, because we can talk about strategy all day long, but unless we've set the right culture, we may well struggle to deliver what we need to for the people of North Wales. So really very important indeed. There is an ask of the board around the endorsement of the NHS Wales Compassionate Leadership Pledge. That is very much controversial within that. We've done a lot of work on what compassionate leadership is. But happy to take any questions on that. And then you see a range of the different types of activities, and particularly just picking up on people who are managers, the important role managers have, and how the development of our managers is a really critical part of how people feel engaged in the organisation. So I'll just see if George wants to add anything else.
No, just to say that the aim is to present the final version of the values and behaviours to the November board.
Yeah, thank you very much for that. Yeah, so it's work in progress. Our role today is very much to support the work and to endorse that compassionate leadership pledge as Carol has outlined. Unrhyw gwestiwn gan rywun gan...
Does anyone have any question? Considering that this is in fact work in progress. It's not finished yet, but Rhian first and then Claire.
I'm just looking at the pledge. Who's pledging to whom? I just wondered, is it an individual? Is it the board? Is it who's exactly making the pledge?
I think the intention is us as a board making the pledge. And there's probably a bit of a story, if I may, Chair, behind this, because quite clearly NHS Wales, which you can decide whether it's an entity or not, but NHS Wales has set out a very clear position in terms of compassionate leadership, and has asked HEIW to develop the pledge that we sign up to. So we're really signing up as a board, with our role being to set culture, to lead, etc. So that's what it is, really.
And that's on behalf of the whole organisation.
Yeah.
Claire.
Really welcome the report. Really good to see the progress that we're making with this, and really good for the board to have sight on it today, as it's still in its developmental stage before final approval. At the People and Cultures Committee, and this is a personal thing, but I think in terms of developing a compassionate culture, it's important. And I can't find which document it is now, George, but the one that's got on a page what living the values look like, and it's got that column at the right that says we do not want behaviours like this.
Yes.
I think it's obvious that you don't want those behaviours if you're behaving in this way. And I just think in terms of staff engagement, having something that's all about endorsing the positive behaviours is an important sea change, and we shouldn't need to be listing what poor looks like, because it's the opposite of what good looks like. So I did raise that in the committee, and I'm just using the opportunity to raise it with the whole board to say, I just think in terms of where we want to head, in terms of how we work with each other, how we behave with each other, having really kind of positive messaging all the time. I would much prefer than lists of not to do's.
Yep, good point, and I think that will be considered in the way it's being developed and going forwards. But
really
it's
great work.
It's an important point. Yeah. Anyone else? Karen.
Anyone else? Karen.
I think I agree with Claire from an outward facing perspective, but having worked with people on the ground, sometimes people actually need to have it spelt out. So I think it's something that might be done more at a team level, or where people's performance isn't, or behaviour isn't right. But you might have to pick that up. I was just cautious, someone on one of the slides, it said maybe we could have the acronym CARE.
Yes.
And having been fallen foul of using the word green for an environmental charity, when it went to Welsh, it just didn't work. So whatever we choose, if we're going down the acronym route, it's got to work in both languages.
Well, yes, let's not rush too much to invent further acronyms for the health board when we've got thousands of them already. But I
think it's a case of get the words right. If an acronym falls out of it, that's lovely. Absolutely. If it works in both languages, it has to, or you don't use it. I just want to say, I think it's in here somewhere. I can't get my head around all these different mountains. I found it so complicated. Would you introduce yourself and say, I'm a Moel Famau, or I'm a glitter? I found, and I think that's something that the health board does. It likes its acronyms that looks nice. It likes its mountains, and we're going to have something about lakes, or, I wonder if that's quite the right approach.
Okay, I'm sure that'll be taken into consideration and working out what works. Different things work with different people, I guess. But Carol, just to
we'll try to find a way on the positive negative. I think there is a way to overcome that. We're talking about the toolkit that sort of sits underneath this, and actually what I've said in some other settings is, we're not looking for 20,000 saints. Some of us will be constantly trying to, work often in challenging circumstances to be the very best that we can be. But we may need to be a bit more explicit about some of those behaviours that we won't tolerate, because that starts to change our culture, but it's about where that features really. And I completely agree, Claire, you know, let's be a positive, forward-looking organisation. And then on mountains, well, you've got mountains, lakes, and I'm not a fan of slogans. So, you know, we could take all of this into account. You know, practically it's about what works, what's needed and what works, isn't it? So, yeah.
Revisited then. Okay. Billy.
Sorry. Thank you. I would say that, you know, the behaviours that we don't want, that we won't tolerate, do have their place, especially to our new staff.
Yes.
Our current staff may be, you know, in the background, it could be there, but I think the behaviours that we don't want, we need to be blunt with our new starters.
That's a good point in terms of there's an opportunity with recruitment to, first of all, the way we recruit actually can influence what people interpret of us as a health board and what we set out in terms of what is acceptable, what isn't acceptable. That's where we can have the greatest influence probably is in recruitment. So really important point to make. Right, you're probably not this either been
So is everybody happy to receive and approve that report on compassionate leadership? The Welsh NHS. Are you happy to receive that? Thank you very much for the important work that's been done, and we're looking forward to continuing to support and see further development. Next item, which again matches the quality meeting and the annual report. Caroline isn't here today because of illness, but I think you've all seen the report, haven't you? Would anyone like to raise anything in that meeting? If not, we'll move on to the annual report on quality, and I'll turn to you, Angela, for that item.
So at the AGM yesterday, I identified that this was our first annual quality report with the information being included normally in our annual report. So I want to present the annual quality report on behalf of Nick and Teresa and myself as the leads for clinical quality execs across the organisation. This is a new and evolving report, should we say. So the plan for next year will be for us to utilise the quality management system quadrants and have it very laid out in a different way, I guess, to make sure that we can show where we've been planning, where our improvements, where our assurance and where our controls have been. But this being the first time, we were given instructions to make sure that our duty of quality was included, our duty of candour, our PTR regulations, and it was identified that we needed to look back, we needed to include that things may not have gone well, look forward as an organisation, looking at our quality priorities, describe the key strategic decisions, look at how we've had our quality enablers, and part of the duty is to have a quality management system, so understand where we were going with that. And you know, obviously I articulated that previous boards and in the AGM yesterday. So I think I've taken this through to the Quality, Safety and Experience Committee on a couple of occasions. It's latterly gone through execs and we've had some more feedback, and then welcome the feedback that I've had from colleagues around the board since the papers were published. I think there is a little bit of disjointedness that has been called out to us, because I think we've been trying to act on some of the feedback we had post the meetings and try to reshape it. The idea is for us to have a discussion, I guess, around the content and whether we've captured everything that we're expected to today. And then we'll do further refinement for it to go to the October Quality, Safety and Experience Committee for us to have a final look and approval on behalf of the board. If that's it, I'm happy to take any questions or any comments. Thank you.
Diolch yn fawr, and as Angela said, the Committee Quality and Safety will continue to receive this report, and our request today is that we can delegate approval to that committee for final sign-off. Ond unrhyw gwestiynau heddiw neu sylwadau.
But does anyone have any questions today or any comments? Gareth and then Claire.
I was just gonna say, I think there's a lot of good content here. There's a question a bit about, when there's a lot of the interesting stuff is in the appendix, which is not necessarily a problem, but perhaps just needs to be thought about. But I do welcome your comment, Angela. I think the question about the camel being a horse designed by a committee, I think and no disrespect to my colleagues on the committee, but I think what's needed now is a step back and give it a single authorial voice. So I'm glad this is going back to committee, because I think, as I said, it's all there, just needs a bit of stylistic tweaking. So I'm grateful, but as I said, I realise that it's sometimes quite painful when you take things through a committee and you do your level best to put it on, and then it starts to sort of walk the original clear vision. So so I look forward to seeing the final version after it's gone to QAC and when it goes to the Welsh Government. So thank you very much for the NHS executive.
Claire.
Thank you. I felt in the annual report there were things in it, particularly around that duty of candour, that I hadn't seen data reported in that way before. And it led me just to think whether or not it would be helpful, because some of it was really helpful and interesting and useful, whether it would be helpful in the future for the quality report to be following a similar format to what's going to end up in the annual report each year. So, because as I say, I looked at that and then felt that there were things in there that we know we need to report publicly annually, but they're not things we've regularly been cited on so explicitly as they are in this paper. And actually that might help them with the reporting each year, mightn't it? Because it's a format the board sees regularly, and then we see the cumulative position when we're doing the final year end report. So perhaps once it's finished, just having a look at ongoing reporting will be useful. And then some of the themes that identifies, perhaps I'll save my comments there for the next item, because that's the themes are the same themes, aren't they? Yes. So I'll wait for the next one, if that's okay.
Thanks. Pam?
So
Mike.
So David. So I think it's really good to delegate approval to the Quality and Safety Committee, and then I think in terms of the next steps, it has to be published, I think, Angela, by the 31st of October, so we can just make sure the full board gets a copy of that in advance of that. I think it's really difficult because I think what's happened is we have the annual report and annual accounts, and this is a different timescale to report in. So lots of the information we will report as part of our annual accounts. So I think there is just something about this is the first year and the timescales haven't quite worked and just reflected for next year. What would be really good just to make sure our annual report and some of this is better aligned, and we don't duplicate some of the things. We can say that's either covered in some of that. So I think we can work on that, but I think it's just the way in which the timing has been done this year hasn't probably been helped for us. So I just wanted to mention that, but we'll make sure the copy is once approved, circulate to board members.
Mike, within
I'm not sure if I'm confused on this or I'm confusing you as well, but as regards to duty of candour, are we talking about kind of practice with patients, or I've experienced it and I found it to be quite brutal. That's the best way I can describe it. Some bad news was delivered to an individual, and the response was, does that mean I'm going to die? And there was no response. So I think there's lack of preparation, lack of training there by the professionals, because it's the question that's going to come, isn't it, if you're doing that type of news. And so I've experienced it firsthand, and I found it very, very brutal.
Okay, we'll come back to that in a second.
Yeah, the duty of candor in here, it seems to be a process rather than a cultural thing. And I think it's the two things, isn't it? You know, this is talking about the process that has to be followed as opposed to the openness and honesty that all staff should be showing at all times anyway. So that was just one point. And I think the second one for me was when we're looking at some complaints and incidents and compliments, all of these things, is it physically possible to put it in a context of how many patient interactions we have over, be it a week, month, year, whatever, so we get a sense of the scale or how small it is. In fact, I would have thought, but this is just guessing, but a context would be good, I think.
No, good point. Can I actually address those issues, but also share what's going to happen to the report? Where's it's going to go to government, of course, but I wonder if it's the sort of report we should be sharing internally as well, making sure staff are aware of it. It's one of the things we picked some of the committees is we have all these detailed, in-depth conversations amongst ourselves, and then staff are not aware of some of the issues that are raised in some reports and so on, and that's something that we want to try and address in some shape or form. So just have a thought about those things.
Yeah,
I can ask you to.
If I say a couple of things and then come back to Ange, if that's okay. I think it's really helpful to have this discussion, and I was reminded that this is the time period of last year where the health board was escalated into special measures, with quality of services being one of the key things. So this has had a lot of scrutiny, a lot of airtime, a lot of contribution as well to recognise all the work on that. But I also think that if we are true about quality being at the heart of everything we want to achieve, it does feel quite difficult to get it all in one report. So Pam, you know, you're absolutely right about the annual report and seeing if we can get things aligned. We might need to feed back to Welsh Government about their timeframes and things. We used to have an annual quality statement. So, you know, I think we've already fed back about timeframes. What's interesting, just picking up Mike's comment really about duty of candour being brutal. I think there's two things here for me. One is the breaking of bad news should be a core skill of healthcare professionals. It's a very difficult thing to do and to land every single time in the right way. But that would be the sort of feedback we want as well about how to improve that. I've also had feedback from some of the families that I've met about where it's been done really, really well. So we can share that. But I agree with Rhian about duty of candour, not just being about a process, but about a way of working. And I think as a board, we set out to be open and transparent, and that's really what it is. It's the proactive openness and transparency. So that's perhaps the test over time. Do we get to be known as a board that is open about its issues, isn't putting things, you know, under the carpet or hope nobody notices? And we do that by, you know, reporting things in a very open way. And I think we've done a lot of that this year, putting out really tricky things. Sometimes we've been challenged back on them. But, you know, I think we're trying to set a new tone. Perhaps Ange could pick up the rest.
Yeah. If I could just come back in the breaking bad news and the duty of candour. So it's very explicit within the duty of policy that we have to report how many duty of candour sort of instances there are, and that is around harm to patients. So if somebody has had an infection which has caused them harm, or a fall which has caused them harm, then we have to formally contact and discuss that and write to the people involved. And that is the process, if you like. Having implemented duty of candour in a previous life, the process is the bit that getting people aware of, the culture then follows, because it's not then about a process, it's about making sure that any incident that is there, that people discuss it and have that openness and honesty as Carol said. But we are doing some work around the communication, the breaking bad news, and identifying how we can support colleagues to have safe discussions with peers on how they would do that. As a student nurse, and I'm sure Carol had the same, breaking bad news or being at a time of death, you were supported to enable you to gain those skills. We want to make sure that we're doing that going forward. From the point of view of the complaints and incidents, yes, we can provide how many out of the numbers that we've treated in that time frame. So we can work that in the background and give the context around that. Sharing will be as we are published on our website. It will be through board. We'll also be doing it internally to groups to identify the patient safety groups through the IHC's divisions, but from a corporate perspective, patient experience group. It will be discussed at the quality delivery group, the exec-led one that I chair. And we'll also be looking to share with partners externally as well. That open and honesty, and then to ask them to give us any questions or feedback about what their experience has been of what we think we've delivered compared to, how they've received it, I guess.
Thank you very much. So is everybody happy to deputise the approval of that report to the committee? And just to note the annual report. Are you all happy to do that? Right, we'll move on to the next item, which again follows the same theme, but this time the report that comes to us as a board for the most recent period on quality improvement. Over to you, Angela, once again.
So this is our improving quality report, our regular report that identifies the activity that has happened in between board meetings and the position that we're currently in. The key points I'd like to raise are the main themes of national reported incidents remain falls and healthcare acquired pressure ulcers. There is some work information in the report that identifies some of the work that is being undertaken. So we have a falls collaborative that meets across the health board. And I have a quarterly executive meeting with the teams around falls, and we've seen significant improvements around that, which we've had external comments around our improvements around falls, more confidence in the way we are assessing patients before they admitted to the hospital, and assessing patients if they've had a fall with multidisciplinary team reviews, and then making sure that our staff are fully trained. And we had just over 2 years ago, a new falls training that was put into place. We had a very, very good uptake, and then everybody sort of lapsed a little bit. So we've now captured back up again, and we're meeting the mandatory requirements for that level of training, which is really positive. But we have got, still work to do. Falls is an issue across the NHS, and it's something that, we can learn from each other as well. So we're making sure we're networking across Wales and the UK on some of the developments that is happening around this. From a pressure ulcer perspective, I've just set up the exec meeting, quarterly meeting, and one of my new directors of nursing in the West is a tissue viability nurse by background. So she's now taking the lead for the organisation on pressure ulcers. We've also appointed a matron for patient safety who's working really, really closely with Vic over in the West. To try and make sure that our policy is aligned, that we're utilising best practice, that we're engaging with our medical and AHP colleagues to ensure that we've got that joined up, understanding of what we need to do and how we need to improve. The number of overdue complaints remains high, but we have got a trajectory to meet by the 14th of October. And we are working really closely with the IHCs. Initially, we launched it with Carol and I meeting with the IHCs on a fortnightly basis. I'm meeting on a weekly basis, and I go through the top 20 overdue complaints, and then the ones that are due to tip over the following week to identify if there is barriers, if they need support, what extra support the central team can give them. We're also, as part of the integrated concerns into the policy, identifying how we can refine what we're doing within complaints, how we can make sure that we're more timely, that we've got the oversight, that we've got the support available, and that we're learning lessons on the back of it as well. So that's working really well, and the complaints team are as part of that concerns hub that meets on a daily basis to show that we can do that cross understanding of where we've got the issues. We had 2 Regulation 28 prevention of future death notices from the coroner, and I can confirm both of those have been responded to with information to the coroner within the timeframes identified, and we've got action plans. It was working around our ED mental health interface and how that works most effectively, and Teresa mentioned that earlier around the team's work that was actively happening. And then we've also got progressing the improvements around isbitaglan fluid ED, where we've identified it's been stood down from a HIW perspective, but we're obviously got an action plan in the background to make sure we've got further improvements that are there. We've got audits in place, we've got meetings and escalation through to the regulation assurance group to make sure we're moving on that. But I'm happy to take any further questions.
Right. Diolch yn iawn. Mae'n adroddiad yna ar gwaith sylweddol sy'n
Thank
digwydd.
you very much for that report and the significant work that is taking place. Any questions? Go to Mike first.
Thanks, it's a very comprehensive report. There's just one thing I wanted to highlight, and that is the End PJ Paralysis Programme.
That was my point.
Oh, do you want to speak to it?
No, Mike, go.
I've got family experience of this in a community hospital. I mean, I think we're all aware of the physiological benefits. It helps reduce venous thromboembolism, you know, lots of things like that. But I think I saw the psychological effect of it. It really does give people a boost to be able to wear their own clothes. And I love the way it was communicated to the older patients. Like, you know, if you wear your clothes, you're more likely to join the escape committee. And so, you know, it is easier just to lie in bed, I suppose. So I think it's a real success.
Yeah.
Are there plans for it to go out to the community hospitals where I saw it into our 3 hospitals? Just wondering.
Hold that for a minute.
I'd not come across the term PJ paralysis, but it really leapt out and struck me. And thinking about my experience of visiting people in community hospitals and the acute sites, it's really significant, isn't it? It really is.
Yeah, it's that mentality of understanding, you know, that this is the bed is a temporary measure, not semi-permanent, you know, so really good. Anyone arall? Os na, Claire.
I was gonna, there's clearly lots and lots of work going on around the areas that continue to be regular challenges around slips, trips and falls. So, you know, the things that we highlight each time, whether that's nationally reportable incidents or complaints we're investigating. And I wanted to just ask Angela really, but on the basis of all the work that's underway, your confidence level around when we'll start to see the improvements that you're clearly working towards and what for you good looks like. Because I guess we have to also be realistic that some people will fall, some people will get a pressure ulcer. So it's just to get a sense from you really about where you think we are on that journey and what the timeline might be where we get to a point where you're feeling you can give the level of assurance to the board that you'd want to.
Great. So if you can take that point and any others and we'll wrap up.
So I think compared to when I arrived 2 years ago, I think the amount of work that's gone in by the teams and their ownership of the harms that are being caused on a daily basis is immense. The difference is immense. We are now seeing, we will always have falls. You know, it wasn't long ago that I fell down the stairs. You know, we will have those falls. But we need to make sure that when we're assessing those falls, we've had the appropriate risk assessment when the patients come in, that the drugs that they're on have been reviewed by the pharmacy, by the medics, that we have got the appropriate environment for them, that we are supporting them by the bedside if they need it, And those are the indicators, I guess, if there is a fall, that I'm more confident that all of those things have been done and they've still fallen.
Yeah.
Because, you know, you could ask somebody to stay in bed and ask for a nurse and then they climb over the cot sides. And that's a really difficult position. Or they get up off the toilet when they've been asked for privacy and dignity. They want to be on their own, but they're outside the door, and then by the time you've opened it, that's the difficult one. But if we've done those assessments and we can articulate them, we've now got a falls dashboard, which the ward managers and the teams can actually look at when the most falls happen. So what day is it and what time is it? So is it at handover? So are we spreading the staff who are not in handover to the right places? And if they can articulate that, then I'm comfortable that I can assure you that we're doing everything. The same with pressure ulcers. You know, have we encouraged the patients to move? Have we put the right things into place? Is it everything that we've done? If the deterioration, is it due to nutrition, but have we made sure that we've been offering high calorie drinks? Is it, you know, that somebody doesn't want to move, so we've spoken to them and got some psychology support maybe to understand why they need to move? And if all of those assessments have been done and it still occurs, then it's sad and we don't want that, but I'm assured that the teams are working together to make sure that doesn't happen. So I guess that's when I will be.
Okay.
But I don't think we'll stop seeing falls, and we might see, you know, reduced, and we also might see less harm.
Yeah.
So if I can just have less harm, so patients with no harm or low levels, and we're not seeing the catastrophic harm that potentially could happen, then I think that's when I'm more assured.
Yeah. So so thank you very much for those points on the report, and it will be good going forward if we can indicate progress. And I think that's what one of the points Claire was making, isn't it?
Yeah.
That where are we heading to? So that journey, Carol and I talk about this a lot, is the key thing for us in the health board is progress. So incremental, sustainable progress. So some of the data can perhaps be brought forward historic, and so that we can see that path, that journey. That'd be really useful.
Could I just put a note on that? I think that's exactly the same for some of the areas we're going to cover now as well, in terms of where have we been, where are we now, where are we heading?
Yeah.
So that's progression.
Yeah.
Can I just?
Yes, certainly.
Yes. As well?
Yes.
So PJ paralysis is amazing, and it has been successful. Community hospital, we will be rolling it out the whole of the acute sites as well. We've got a patient deconditioning group that when Gareth was director of therapies, we joint launched it. And actually one of Teresa's deputies is now the chair of it. Trying to get some ideas and things that are working in different areas, and then scaling them up at pace to make sure that we are assessing patients when they come in as to what their level of activity is, what their level of conditioning is, and then be able to identify when they're discharged, where they are then, and making sure we've not had that dip. Also looking at hospital-acquired pneumonias. We've got a piece of work going on at the moment. There was an infection control report that's now been taken through that group to identify how we can reduce that happening in hospital, because it has some catastrophic outcomes if you have that. So we want to make sure that that's included. So in a future QSE or board, happy to bring back some of the outputs of that, because I'm really excited about fits into the 6 goals work within that, but really excited about some of the opportunities, and those initiatives are being developed from the ground, so people are seeing what they can do and then making sure it's working.
Great, definitely on, and it's great to hear about the connection staff have with leading that and the difference it makes. So that's excellent. Probably not busy there have been.
Right, so really happy to accept that report with thanks for all your work. Okay, thank you very much for that. I think we've now reached the lunch break. So we'll have a break now for lunch. We'll reconvene at 1:15. 1:15. Everybody happy with that? Right. We'll take a short break now then for lunch, and we'll reconvene at 1:15.
Iawn, a croeso nôl I gyfarfod bwrdd iechyd
Right,
Prifysgol
welcome back
Betws
to the board meeting of the Betws Cadwaladr University Health Board for the afternoon session. The first item this afternoon is a report from the Chair of the Finance, Performance and Information Governance. The papers are, or the report is in your papers, but I'll ask Gareth, the Chair, whether he would like to highlight anything from the report. Gareth.
I don't think there's anything particular I need to raise on the report. We should try to keep this pretty short and like the things that come next. But there you go.
Diolch yn iawn.
Great, thank you very much for that then. So are there any questions? If there aren't any questions, then we'll turn to the actual report itself, which is the Integrated Performance Report, and ask Russ as our Director, over to you.
And the next one, please.
Dear Chair, so with the report, we'll go through colleagues and then come back to myself. I know we've discussed urgent emergency care and we've also discussed quality earlier, but in case anyone wishes to add something, then obviously we'll take on the urgent emergency care aspects, and then George will just talk us through the people and performance. Come back to myself. I'll talk us through planned care, if that's okay, Chair. Yep. And then we'll take the finance report as the next paper.
Great.
Yeah.
So from a course perspective, as Russ identifies, most of what was included has been discussed in previous reports. I would just want to put attention to the clinical coding compliance and the plan that we've got in place to improve that with recovery plan in recruiting more trainees and supporting the work. We've had a slight improvement in months. Obviously, that isn't significant, but we will hope to see that progress as time goes on.
Yeah.
Thank you all. From urgent emergency care, we're pretty much covered in the earlier section. I mean, from performance point of view, obviously we're keeping a close eye on that. And as part of the 12-week focus, we'll also be ensuring that our trajectories that we've signed up to externally and internally are translated in terms of day-to-day position, what that means, and the allowance for breaches, so that we can then start aligning it much more to the board reports at the time.
Very much. Good.
It's me next, sorry. So yeah, just a few points really. So sickness remains at fairly consistent levels, higher than we would want across the organisation. Obviously the culture, values and behaviours work will support the reduction of sickness going forward. We're also finding, like our population, that staff are often presenting with more complex health issues, and the discussion we had this morning about wellbeing will again support the reduction, supporting staff there. Turnover of staff who have been employed for less than a year is quite consistent, but is at 14%. So I think that's an area we might want to look at a bit closer to understand why that is. And you will see that there's been a great reduction in disciplinary cases since January this year, and focus remains on improving that position, but also the culture and behavioural work will support that, and also the work on just culture as well.
Thank you. And just briefly on planned care, if I may, Chair. So clearly, cancer performance really does impact in terms of short term where we find ourselves with planned care, because we are fighting those two really important agendas for us. The urgent emergency care aspects of crowding out essentially routine elective capacity. So there's a real alignment to the earlier agenda item to make sure we create capacity and then we treat in turn. But I have to say the operational teams through the delivery meetings are really engaged with this subject matter now. And they're creating some really good innovative solutions as to how we move forwards. We have eradicated the 208 weeks. They're all booked now, so we don't have any unbooked as of today, and if any do move into that unbooked arena, then we are urgently moving those into a completed pathway. The 156 weeks have significantly reduced as well, and you'll see that through the chart. So week on week, we are seeing improvements in performance around our extreme weight position. We have commissioned additional insourcing through the health board support as we had the discussion in detail in July's meeting. The endoscopy has already come online, so we're already seeing a circa 30 to 40% increase in endoscopy capacity. We're out to the market for dermatology as well, so that work is due to conclude, and we're looking to commission. That again will give us a massive improvement in terms of our performance. And both of those elements will drive improvements in our cancer performance in terms of the backlog, but they'll also drive improvements in terms of the 156 weeks and extreme weights. So we will see that move fairly quickly. The cancer performance, as we tackle the backlog, that's when those individuals become a breach. So we will see that performance reduce. We are profiling that performance so that we can share that through the next meeting. We will take that reprofile performance through people because, so we've got committee oversight. In terms of the 156 weeks, we'll continue to report those gains as well. Also, in addition to that, there's 104 weeks all Wales target, and I think we alluded earlier that's a really important target for us and Wales' position. We are and have done an awful lot of work. I'd say the operational teams and the IHC leadership. They've developed a grounds-up forecast model in terms of patient waiting, and we've applied some metrics to that in terms of the insourcing capacity coming on stream. And that moves us into an outturn position of circa around 7,700 patients. We'll share those revised trajectories with people at its next meeting so we can interrogate those still further. There is an opportunity for us to improve performance down to the trajectories we put forward in May and slightly improved on those trajectories with additional investments, and that's being considered through Welsh Government channels as we speak. And again, we'll share that information back through PP. So I think it's certainly an improvement from where we were, significant change. I would say there's substantial buy-in through the operational and the IHC leadership teams, and we are seeing that sea change really, both in our extreme weights. It's still fragile. We still need to keep that focus. We're not delivering as we would like on treating turn, and we need to keep the pressure on to move that model. But once we treated our suspected cancers, we'll then be able to free up our internal premium working model, which is waiting list and and that will then support routine elective capacity delivery. So it is good progress, really good progress, but there's more work to do.
Great, thank you very much for that address. Cwestiynau, unrhyw un eisiau holi cwestiwn? Mike.
Does anyone have any questions? Mike first, then Rhian, then Gareth.
Could I ask in terms of general trends as regards cancer, are we saying, or are we predicting that the inevitable graph, it's been 1 in 8, 1 in 4, 1 in 2, are we going to get to 1 in 1? Because that's the direction of travel that has been for quite a few years now. So, and if that is if something tells me differently, I'm willing to listen.
Sure.
But I'm just wondering whether, as regards capacity for the future, it's something we've got to be open-minded about and possibly have to look at.
Okay, we'll come back to that. Rhian.
Thank you. It's good to see progress, obviously, and that the lists are coming down. But of course, it's all coming down at a cost, isn't it? And we're going to reach a point where that is not sustainable. And we've got to get our processes and streamlining and whatever in place so that we can then not spend so much on insourcing or premium working. So I just wondered what sort of timescale we've got for that sort of crossover from getting them down to being able to sort it ourselves so it doesn't go up at an extra cost.
Okay, the point. Gareth?
Yeah, well, I first of all want to say, I think PFIG's keen on trying to keep on top of this. I think there's a lot of really good work going on, but we keep on getting brought back to the fact that when you look at the figures, there's only 4 out of 34 of our access and activity measures in which we're on target, which is really still pretty depressing. I don't want to bring us all down, but it's true that we've got a really big challenge on. I did notice, to pick up Rhiann's point, that there's a statement, we've got two different sets of data in here, which is fine because we've got the end of July data and then we've got more update, which is, it's really good to have more update. And I would appreciate if you can just, if it's possible, Russ, if you can just give me the figures on where we are on 156 unbooked appointments. But I did notice that that at the end of July, one of the things that happened was that by doing the whack-a-mole on the 208 weeks, that the numbers from 156 and 104 had gone up because so it's quite a long journey, I fear, but we are making progress. And my only real worry is about, you know, the sheer amount of effort that has to go in to sort of deliver it. It's obviously putting a strain on a lot of people, but we just have to do it. But yeah, I'd be interested in just the most recent figures, as I know you're updating every week. And the only other, it's this relatively small point, but I think it's an important one, and that one of the things that's attributed to the problem with therapy waits is not just staff capacity, which obviously is not something we can wave a magic wand on, but is the question about space. And that brings me back to my sort of probably boring point, but you know, about can't we be more imaginative about following the example of audiology and moving things that are currently secondary care services into primary care. Now, obviously, the primary care premises don't have the room either, but where they do, should we not just be holding clinics more out in primary care locations than saying, oh, well, we can't do enough clinics because there's no room in the hospital premises?
Good point. Claire.
It's useful, I think, on the nursing and midwifery sickness, so stress and mental health being two key factors, and on the turnover figures of people leaving, within 14% of people leaving within the first year. I would really appreciate perhaps at the People and Culture Committee more of a deeper dive really about understanding what we're able to do and what we are doing to try to address those, because the one about the turnover in the first year is it's really really disappointing and quite scary to think that people join with good intent and stay less than a year. So there's got to be something about our recruitment processes, what people understand the job roles to be that they're turning up to do, or recruitment decisions. So it's just be good, I think, at People Committee to understand that in a bit more detail. And then on, it's probably the same point Gareth's just made, I think, but he was perhaps more eloquent. In terms of children and CAMS and mental health and ADHD and ASD assessments, we're doing quite well at assessing people, but we're doing terrible at starting treatment. Is that your point about premises? And then also,
I was looking more at the physiotherapists, like but there's an element, I think.
So my question is it not the same people with the same skill set that do the assessment and do the therapy, or is it different people? And if it's different people and different skill sets, what are the issues and how can we address them? Because those have been, again, underlying problems now for quite some time. And then the final question was, and it might be me and graph reading, Russ, but on the 104 weeks, my understanding of the graph on page 13 of the cover paper is that we're anticipating those to increase to 10,000 by the end of the year. So the trajectory is that they're currently at, what are they, about 7? So how are we going to, and then there's a little note that says we've asked Welsh to go for more money. So are they going to get to 10 if we don't get any more money? Or
getting to 10
because we're supposed to get to 5, aren't we? I am understanding that right, I think.
We'll come back to that in a second. So the issues on the workforce that you've raised, the need for us to look in detail, and the People and Culture Committee can do that if that's okay. That piece of work I think will be quite useful. Some of the other questions though, I'm sort of seeing who wishes to take those, but Billy first of all, and then
really welcome the changes that we've got in workforce processes and the move to just culture. I think that will link very much with what we were discussing before lunch. The duty of conduct.
Yes, good point. So can you coordinate who's going to field some of the answers?
Just done a deal.
Maybe Teresa has some responses in some, I don't know, but you can
Yeah,
You can
so I want to
conduct the orchestra.
conduct the orchestra, sing a good tune. On cancer, you know, Mike, this is really important in terms of our forward planning for services. Is what's going to be happening with cancer? And you're absolutely right. And some of those cancer rates going up. A couple of reasons. One is, on the whole, over the last century, we're living longer, so that's a good thing in a way. But the other thing is that we've also become more unhealthy, and we're not, as a society, taking all those steps regularly that we can do to prevent, so the exercise, the diet, or that sort of thing. But there are some good things in there as well, which is back in the day, if you had cancer, it was, likely to end in your premature death. People are living with cancer as a longer term condition now, and having many new therapies and that sort of thing. That said, if we were to compare cancer outcomes from Wales with Europe, we are way behind achieving the same sort of outcomes of the best in Europe. We're seeing an increase in about 9% over the last year of referrals coming through for cancer. That is probably not enough in order to pick up cancer at an earlier stage and to achieve the outcomes that are the best in Europe. The challenge I think we've got is, whilst we're trying to get earlier tests and more early intervention, we've not got the system, the NHS set up to cope with that. And if we think we need to come back to diagnostics, really think about what's the diagnostic strategy for the next 5-10 years, and what's the follow-on from that. So a lot of work needed on a longer-term cancer approach, so that we can plan for the future. Rhian, on planned care at a cost, yeah. And there's two things here, I think, Rhian. One is we've still got the bubble of the backlog around. So for some specialties, it is a backlog only issue, really. For other specialties, so if I take dermatology, a lot of referrals coming on skin for the suspected cancer pathway, and we'll put a footnote on that. So different specialties have different issues, if you like.
Yeah.
What we really want to do is to move that investment that we've had from the government, £34 million for planned care, into more sustainable solutions for the longer term. With some of that work is happening. Not quite quick enough, but we've got some sessions coming up on specialty basis on orthopedics. I think we're going to have one on ophthalmology. I'm chatting to the dermatology community this week, one on dermatology, so that we can start to bring in those different ways of working. So it will go as you it'll go like that. Physio in the East in particular, I know that the therapists, I know maybe Teresa will want to comment. We discussed this at IQPD this week, and then I'll leave Russ to do the 156 unbooked numbers, if that's okay. Right. And then we go to Teresa.
No, that's brilliant, thank you. So really, I guess to also give my spin, I suppose, in terms of where we're using the resource. So absolutely, we are at the moment really focused in on using essentially premium working in order to correct what is a gap within our service demand versus what we're currently seeing as patients through our in-house capacity. I think there's a dual approach based on specialty, and there'll be a different outcome for each specialty based on where they sit. But essentially, what is our capacity? And that's against what we are currently seeing and what we have as potential to see. So that's about benchmarking, making sure we're productive and efficient within that model as well as an overlay before we look to how we invest, because we want our services to be productive before we start assessing that we're going to invest back within them. And then there's demand as well, which really links into the earlier agenda around where we go with prevention, because demand could be what's currently effectively coming through the referral patterns, or that may or may not be appropriate. And actually, we might be able to avert some of that demand through investment into that front loading of the prevention, which again is a really good agenda item for us to discuss. So I've seen that happen before, and people that have growth funds into primary care on the basis that manages future demands coming through what would have been through the hospital accommodation, and we don't have the infrastructure to service. So there's quite a bit of work on that, both demand and capacity modelling by specialty that's currently in train and working, but we've got this backlog and we're not going to get that work concluded in a timely manner for us to be able to take a substantive judgment on investment. And then we move those resources substantively into our in-house capacity and start investing in our services, which is absolutely what we want to do. That's the best bang for our buck, isn't it, for the 34 million that Welsh Government are offered and we've taken. In terms of where we find ourselves today, we've got 156 weeks. We've got 1,264, I believe, unbooked. That was the information that was provided for me yesterday after the escalation meeting through the planning care session. We've got 40 patients currently waiting within 208 weeks, which have booked appointments. There's this strange model where some of those revert back out and then revert back in, but essentially they are all being taken care of. So the national reported metric will suggest around 40 patients for us at close of the calendar month, but they all have slots to be treated. It's just about building that capacity. And we've already mentioned physio, haven't we? So yes.
Teresa, yeah.
Yeah, thank you very much. I haven't got much to add, to be honest. Much has been said already. In terms of therapists, I think the state is a massive challenge at the moment. I think it's back to what Russell's been discussing now. I don't think we've ever done some very sophisticated work on demand and capacity within the board. You know, I think this sort of appears out of the blue, really, these problems. So we are dependent very much on the estate's strategic plan. We know that there's work going on. I speak with Mike very often about the challenges around mental health, but the challenges are the same in terms of therapists as well. But I'm more than happy to work with you on the estate's work, and of course with new members as well as we look forward. But I think Gareth is quite right. We need to look out of the box, look to our communities, see whether we can use resources. I think that is the challenge for the therapists. There are other challenges, you know, you've got staffing, etc. You know, we are working differently, so the progress is different, but we don't always look at modelling the capacity, because we usually and traditionally look at other areas first.
Shall we just pick up the final point that Claire made, which was, what's the numbers? So the 10,000, the 5,000 and the 7,000.
Yes, sorry, apologies. I did have trajectory written down. I was wondering, so yes, so when this paper went forward, we hadn't concluded the work with the IHC. So our trajectory was to move towards a 10,000, which gave us that 5,000 gap. And current performance suggests that 31st of March, that's where we were heading. We've done that work with IHC colleagues, and they've submitted their detailed plans reverse up. We've overlaid those with now when we believe the insourcing contracts will take place, because they didn't include the benefits. So endoscopy already happening, dermatology, we're going to conclude that tender process in a matter of weeks. Once you put some of those overlays with validation as well, so there's a piece of work on validation, it moves us back to about that 7,700, but it's just a timing issue that this report went through. That report's been sent back through as well and shared, and Welsh Government colleagues are supporting us with the profiling of delivery of that activity as well. And then there's additional opportunities for us to seek additional resources, which would then bring it down below the 7,800. And that's when we hit the 5,000. And the dotted yellow line, that's our May plan submission. Clearly, we'd be sort of hovering at delivery of that based on an additional allocation of resource, which technically wasn't the basis for the May submission, but the numbers would equate back around that value.
But we just need to remember, don't we, that the target, the Welsh Government target was, although I think they recognise we're not going to reach it, was 0, wasn't it?
Yes, absolutely. 0 for all stage 400, stage 104 weeks stages.
Okay, iawn, diolch yn iawn. Ydy, pawb yn hapus I dderbyn yr adroddiad?
Thank you very much. I'm really happy to receive that report. I'd like to thank Russell and everyone else for all the excellent work that is taking place. A lot of work is happening, I know, so thank you very much, Russell. Next item, Russell, is yours too.
Finance report, if you can just give us some highlights on that, please. Thank you.
Yes, thank you, Chair. Just really quickly, the highlights through the finance report. So, as you're aware, signed up for a 19.8 million deficit plan, just below the £20 million or 20 million control target that was set by Welsh Government. To do that, we need to hit a £48 million savings ask. And in addition to that, we have included the £82 million that we were in receipt of again for the 24-25 financial year. We had that for 3 years previously. It was due to come to a close on the 23-24 years. So our 24-25 plan effectively has £82 million of one-off funding and a 19.8 million deficit with a £48 million savings ask. How we're performing at the moment. So in August, we had about a 1.6 million adverse reported performance to plan. So we had a 3 million in month deficit position. We've gone to a 16.8 million deficit year to date. So we're at £8.6 million adverse to plan. And clearly we're seeing some capacity issue costs. We're seeing continuing healthcare increasing costs. We've still got out of area mental health costs. So there's a lot of work going in the background to try and reduce the cost exposures, and savings again has slightly contributed. Although savings, we've moved now to 42 million, just over, of the 48, and the majority of that as well on a full year effect would be recurrent. So a 38 million pound recurrent savings to performance. So that's really good progress from where we were. We're pushing the savings to get to the 48, and then we're going to continue on that drive with savings delivery, because we don't want to start next year from a standing start. We need to build for what we're going to have as a savings programme as we go into 25-26. So what we're doing, we're meeting through essentially escalation forums with our IHC leadership teams and other areas that are experiencing financial difficulty to understand how we can move those costs down. And those meetings are happening this month. We do forecast every month, which is why we know we have a 20-25 million pound risk to delivery, but we're now homing in on those forecasts. And we are seeing that some areas are expecting to recruit current vacant roles, which haven't been able to be recruited to previously. So there is some challenge going into those forecasts as we speak. And clearly we're having conversations about how we live within our means, so we can give ourselves assurance as a board as we go forward that we can deliver the plan. And we will take that back through P figures of reforecast. The overall climate in Welsh Government is one of challenge financially. There's a lot of health boards experiencing significant financial difficulty. And so there is a real focus back on financial performance again. Some of that delivery and assurance through those meetings that are going to be held will determine as to whether there is available resource to support further movements within planned care, as we've discussed earlier. So there is a lot riding on this. And just to give you, because that seems a little bit down, doesn't it? So to give, because I believe someone told me this, it's International Week of Happiness. You're experiencing that through the board, I'm sure. So to give a bit of light on the end of the tunnel here, so we need to save about 1.6 million a month. We're spending 1.6 million a month more than we should, but we spend 190 million plus every month. So it's 0.8, 0.7% reduction in month. So it's tantalisingly within our grasp. And of course, the £82 million becoming a recurrent allocation for us going forwards is a really good driver for us to try and find that small percentage improvement as we go forward. So there is an opportunity. Clearly, there's opportunity for us to get there. We're doing a lot of work in the background to make sure we can assure ourselves that we have a route to delivery. And clearly, from Welsh Government perspective, there's a lot of focus back on the money.
Diolch yn iawn. Ac mae Gareth yn cadeirio.
Thank you very much. And I think the chair that Gareth is chairing are also looking at this work in detail and monitoring the progress as well. And we also get regular reports on the performances as well, as we see today. So Gareth.
I do want to say, I think that, that we are doing really quite well at the savings, and I think, you know, I do want to pay tribute to Russ and the team for the work that's going in there. You know, obviously nice to get to the 48 quicker rather than not, but 42 is pretty good at this stage of the financial year, I think. So and you know, I think you're right, Russ, aren't you, that it is sort of tantalisingly close to get to an outturn that will give, if not the week of happiness, the year of happiness to the Welsh Government. I've got to say, despite the fact that I'm normally fairly good with numbers, I'd just like to unpack a little bit what happened between July and August, because it looks as if it got a lot worse. On the other hand, in July, we had a big one-off accountancy gains, but we had some accountancy gains in August. So actually, was August slightly worse than July, but not a lot? And do we know why that was, or would that be normal? Whatever normal is. And then the other question I got was completely separate, and I seem to remember we had this last year, but it may be it's like Groundhog Day. But I was intrigued with the expenditure pay line, not about the pay, but the fact that there's been an increase in the budgeted full-time equivalents from 19,130 in April to 19,789 in August, which is a 3.5% increase in the number of approved budgeted staff. And I'm not sure how that's. It may be that it's specific posts that have been funded that are short term, but I wonder whether somebody can reassure me that, you know, for all the good work that's going in, that our staff always seem to be growing, you know.
Yes. Just before you come in, Russ, just check. Mike, Claire. Mike?
No, you go first.
Mike.
Okay.
I got too much.
Want to know what? This arrangement that we've heard in the media about cross-border, we can call it that, provision, is that something that we need to take into account? I'm guessing it could increase our costs. Presumably these things don't come for free. Is that something that's been taken account of, or is it impossible to know because we don't have the details yet? Just wondering.
Yeah, I think your last sentence sums up, we don't have the details yet, and when we have details, if we have details, then we can build that into our trajectories or whatever. But I'm not sure how it's going to impact on our financial performance actually. But yeah, we'll wait for details.
Thank you,
Claire.
So my question is a lot similar, exactly the same as Gareth. So I guess just a summary around your confidence level, Russ, that we're going to be able to find that additional shortfall, because we've got to get to a place where that 82 million becomes recurrent.
Yeah.
So just your confidence level, because obviously there's been accountancy gains that have helped, some savings, and even if all of those pipelines were delivered, we're still short. Where's the rest going to come from? And then just one on capital, and this is a bit of a pedantic point, but we say in the paper you always spend less in the first part of the year. Well, I'd argue if once you know what your budget is, you can start your procurement straight away, so that shouldn't be an issue. But if we do know that, let's profile it different, so we're not reporting that we're not performing against.
Yeah.
We don't have to take the number and divide by 12, do we? If we know that
No.
we always spend it all. So it is a pedantic point, but it would mean we wouldn't have to discuss it then, because it would be like, actually, we're on target.
Yeah.
Thank you.
Okay, Russ, any thoughts on some of those issues, please?
Yeah, so the capital one, we'll look at the profiling. Absolutely, we do profile, so it's not an equal to health model, so we are behind on what we classified as our profile. So there is something for us to push on with that, and clearly for me, I think there's a risk to us actually being at this level of the year. And you, as you quite rightly suggest, you know, the reality is, whilst we can't push ahead and spend on what are major capital works and capital projects, and so, for example, a big part of our project or our programme this year is the Llandudno development.
Yes.
That will be as it progresses through the year, and building infrastructures, once they're approved, they do take time to come on stream. We've got medical equipment, we've got diagnostic kit, we've got effectively IM&T projects. So we can be committing that resources in advance. And whilst we've profiled it, we are slightly behind the profile. So I want to push that if I can. But we will go back and have a look and take the opportunity to make sure that the profiles are robust. And if we need to reprofile those for future reporting. So they are a realistic signal of where we're moving behind on plan. because we do have to spend within £500,000 of our allocation in year. So it is a key performance metric for us to deliver. So quite focused on that one.
Okay. No,
I was going to come in after you finished.
Oh, okay, okay.
What we agreed with.
I mean, the expenditure from July to August, we have seen increase in costs. We've seen those in non-pay. Continuing healthcare has gone up. We've also seen some cross-border transfer of patients, which has effectively seen an increase in cost as well. So we have seen that cost creep. It's extenuated a little bit because we did have that one-off accounts again, which was quite significant in July. So we had a £3 million one-off benefit in July. So I think what we're seeing is a consistent cost exposure, but they're not having the benefit of our one-off accounts again. And then CHC is driving additional non-pay costs, unfortunately. So there is a trend where we need to reverse that.
Okay, Carol.
So can I just clarify one thing, because there is a reference in the covering paper to fortuitous accounts gains in month. So is that referring to August or July? Because I knew about the July one, but
there are some
in August,
but
they're less.
But they're a lot less than
okay.
3 million a month would be
welcome. Don't get too excited by the prospect, because
no. It's I wasn't trying to unpeg.
Sorry.
Just on the whole time equivalent shift. So that's around where we have allocated resources, and then that resource is coming out of the reserve. But I think for a comprehensive answer, we'll include a reconciliation of that as we can share that around the board. But it just reflects the developments that we're
recruitment.
You should just in there.
Yes, I would just like to add one thing. I know that Russell has a lot of concerns, but we've also got finance directors who are very, very good. I know that you're worried, Russell, but we've got very good finance directors. So I think we've got all of that, and I hope that your concerns will be less in the future.
This is the key thing, really, because there's a lot of, Russell's doing a great job and the team, but it's painful.
Well, it's I think that's really
not the job of a director.
I think that's really well put. There's something about short-term pain for long-term gain, but the associated thing is the way we approach finances in the organisation. That's the big gain to make, actually. The way we invest, what we're doing with our money. That is equally as important as creating savings of the millions we're doing, and it's that sort of discipline and understanding that we're developing as well, hopefully, so we know exactly what we're getting for the money we invest. But final thoughts from Carol.
I thought Dylan was going to ask for more capital investment. I'm sure he is.
From the underspend.
Great. So I think Claire asked about confidence, really. So I was just trying to think where we were this time last year, and we had to really put the brakes on really quite heavily in sort of August, September last year. And it talks to your point there, David, about trying to move the organisation to one that is financially disciplined, focuses on how we invest and the value we get from that. And I'm sure we've still got quite a lot of work to do on that. I guess, Russ and I had the conversation the other day that day 5 in October is going to be really important. So where will we be in October? So that's only 10 days or so's time, isn't it? And I think we may have to come back and think about some of the choices that we might need to make, because we really do need the £82 million to be secured for us. We know we're not delivering the performance requirements that the Welsh Government set out in other areas. And we're so, as Russ has said, so tantalisingly close on the finance. And when we start to think about annual plan, 3-year plan, some of the things that really get plans over the line of whether we've got a financial and performance regime, and whether we're improving performance in other areas, and whether we're becoming an effective organisation. So these things matter to us. So if we're that close, but we could be losing it for being that close, I think we need another conversation about what more we should do.
Great. Diolch yn iawn. Pam yn hapus I dderbyn y adroddiad a
Great,
diolch
thank
yn
you very
iawn.
much. Everybody happy to receive the report, and thank you very much to, again, the significant work that is being done and the progress that is being done. And thankfully, we've got finance directors who are also very, very keen, that are doing some excellent work as well.
Da iawn. Ymlaen, da ni'n rhedeg ar ôl amser
We
rhywfaint,
are
felly...
slightly behind time, so let's hope that we can catch up these next few items. The next item, developing an integrated health and care centre in Holyhead. And we're keen to have this in the agenda because even though we will be having discussions in the private session because of commercial considerations, but there is an opportunity here for us to note our intention on this agenda item. And in the absence of Chris, I'll turn to Carol just to say a few words.
Thanks ever so much. It's a pleasure to bring forward the strategic outline case for an integrated health and wellbeing hub in Holyhead. It's been a little while coming, is what local people in Holyhead and elected members would be saying. And I was across there a good few months ago now in the current premises of the GP practice, one of the practices there, and could see at first hand the difficulties of that provision, but also hearing the real potential that there is to develop a more integrated approach to health and wellbeing in Holyhead. Just a reminder of the needs of the people of Holyhead are particular and specific, and we've been having discussions, just linking the item earlier, around health and wellbeing more generally, but about children and young people, and really providing a different environment and opportunity for folks. To specifically mention the work of the IHC in the West, and Chris Rudgley in particular, Chris Couchman and colleagues. So there's been a lot of work going on there, and the cluster in particular, and the cluster leads have been key to this. As you say, David, there is a separate part in private because of the commercial confidence here, but what we're asking is the endorsement. At this stage, it's a strategic outline case. There are a number of steps, so this isn't going to be built next week, but it's the first really concrete step in moving forward on a new development. And when we talk about primary and community care, as we did earlier, it is these sorts of investments that start to make the shift a reality for people. So we're asking a couple of things, and we'll obviously want to consider the commercials later, but we are going to be looking for support, particularly in the partnership space, the integrated funds that come through the Regional Partnership Board and the Transforming Towns. So I'll just stop there.
Diolch yn iawn, Carol, ac mae'n werth nodi...
Thank you very much, Carol. And it's also worth noting all the joint work that is being done with Anglesey County Council on this project. It's a very important project, and I must say that the support we're receiving from the County Council and others to realise this very important project. Any questions or comments? Remembering, of course, that it will be discussed in full during the private session. We're all happy to approve. Are you? Great. Well, thank you very much for that. Thanks to everyone who's involved with this very important work. We're really looking forward to see the next phase. On to the next item, which is the update on the annual fee rates of continuous healthcare. And again, in the absence of Chris, I'll turn to Carol. That's okay for you?
With this item as well, please. Thank you.
And Russ may want to come in because Russ has been helping with this. So hopefully the paper's reasonably self-explanatory. We took a decision as a board in May in relation to setting the fee rates. We alerted the board in July that there were some discussions underway, and those discussions have now happened, and we've really talked about two key strands of work. One is in year, in terms of the fees that would be I was to say agreeable, clearly,
Negotiable.
Negotiable, yeah, that's the right word. But really importantly, sitting down and doing some strategic work on how we
Yes,
commission
yeah,
differently.
yeah.
We've talked about this earlier in terms of community care and those sorts of aspects. And the private sector are actually very important players in this, but they're not the only colleagues as well that offer support in the community. So being able to sit down and get a strategic approach is really important. So the outputs of those conversations are suggesting that we look to revise the CHC fee based on largely the issue relating to the real living wage and the impact of that, to a percentage of 6%. So just to be aware that we have been funded only 3.7%.
Yeah.
So just on the back of the last conversation, it is money we need to take from elsewhere to support this. And we have been, straight with colleagues in the sector that is the impact of what would need to happen to achieve this. So perhaps I'll just bring Russ in for any additional comments.
Yeah, only to say the initial allocation was based on the inflation allocation. Obviously, we have 3.67%, less than 2% savings request. So clearly this offer goes way beyond the allocation we've received to support this nature of business. And as Carol suggests, we'll need to find that resource within the wider health board's modelling. So inflationary pressures will have to be contained in other areas in order to be able to facilitate us being able to offer this level of increase. And this inflationary calculation is based on real living wage plus the recent announcement of the additional inflation for payable for general or agenda for change. So essentially, it's now a real composite for inflation, and clearly officers through discussions are looking for this to, if in effect, supplant a discussion on fee structure. Whereas this is purely for an inflation allocation, and those further conversations will allude to what the fee structure should look like as we go forward and give us a more concrete platform to understand what we're doing.
Great, diolch yn iawn. Cwestiynau wrtha gynta.
Thank you very much. Questions?
Obviously, this is a really important aspect of the service that we offer, really important, and generally across Wales, across the UK. The number of complex cases are increasing, so we can look to CHC costs continuing to increase. Obviously, we also got these questions coming forward, as we know from the letter from Care Forum Wales, which is obviously again asking for more than we've allocated. But there's a lack of control for us in that arena. That's what I see. And I remember we had a previous discussion this year when we were talking about maybe other ways of finding other ways to provide. So I have a memory that it was suggested that we could provide this ourselves more efficiently, more in control. So I'm just wondering, one, have we started to model that? Can we model that? Can we look at, is that a viable thing for us to consider seriously? It will increase our control. It may still be expensive, but we will have more control.
Good point. Anyone else? So the two aspects to this is that there's the short term, which have been presented today, which is addressing the level of fee for the current cohort, if you like. And then the other question, which Eartha suggested, and you have as well, what does the future look like? what do we need to do to prepare for future provision and model, and who are our potential partners in that space? So we're not going to answer that one all today, but it's on our radar, and it's really important as mentioned. So,
and that will kick off in the autumn. We've agreed that thinking through and start in earnest later in the autumn.
I think that's really important, but I just very small point, which was, and I know this is happening because it's all happening in real time, but what's the position in the other health boards in terms of their uplift? Because they all have the same issue, that 3.7% is what they're being given for compensation. So do we know, or is it, or are they taking them to the boards on the same day? Because I know that
they're all in different places. So I think we're more in line with Swansea Bay. I think they're about 5-point-something%. Some health boards are a little more than us as well. And it's really difficult because it's not a blanket. Costs are different in different places and different types of homes and all of that sort of thing. So we like to try to keep an eye on where everybody else is as well.
Yeah, absolutely. Okay, diolch yn fawr. So, ydyn ni gyd yn hapus?
So, are we all happy to ratify the fees and rates that have been set? We also note the discussions that are ongoing with Social Care Wales, and I'm sure that they will continue. But we also note the desire to look to the future and to consider how we actually plan this provision for the future, as has been suggested now. And I suppose those discussions will take place in the autumn. So are you all happy to approve what has been noted in terms of the rates and the fees and the 6% increase? You all happy to approve that? Yes? Everybody in agreement? Thank you very much. And we look forward to further discussions, I'm sure, in the future. So on we go to the next report, which is the annual report around the Welsh language. And I would like to invite Teresa to present this report. We had a very good presentation yesterday in our annual report, just down the corridor. It was a very comprehensive presentation. But now's an opportunity for you to perhaps highlight some of the things from yesterday. Yeah, thank you very much, Chair. I will be brief. I think the report is fairly self-explanatory as it is. It is very full of information. But I have to say, from the outset, it has been a very successful year within the Welsh language team and the Welsh language in the University University of Wales. But this is a very important report because there is a requirement to present this to the Welsh language commissioner. You've got 2 minutes of 1 today, because at the back of the report, we've got a report on more than just words and our work around bilingualism. Now, I would say, as I said, that this has been successful. The team have been recognised on a national level around 2 specific areas. I think they've won 2 awards. So they've received 2 awards, and they've also been nominated for the Wales NHS Awards. So I've got my fingers crossed, and hope that you'll have your fingers crossed as well. So in terms of highlights, I would first of all pick up training. That is working really well. We've in fact got a queue. We've got a waiting list for the training. And I think that says a lot, doesn't it? So I'd like to thank every learner and every member of staff that are helping our learners. I'd like to also thank the board, because within the board, we are talking about the Learner of the Year, and I'd like to thank Helen and the Vice Chair for joining us that evening. It was a lovely, very successful evening. Everyone is still talking about the Welsh Learner of the Year, and we'll be preparing for the next one soon. And in terms of more than just words, you will see the ESR statistics. I'd like to thank the Moors group who've done so much work with us to ensure that we're able to show the increase in the number of people who have provided information about their level of competency in Welsh. And again, we've seen progress. So I'll leave it there, Chair, but just to say, that I've been reflecting on the previous year. You mentioned allow presenting yesterday and providing such comprehensive information. Now there is more work to be done on standards, and there is a bit more work around consistency. That's a theme across the health board, but I think we need to be more consistent in terms of the offer across the health board. We've got another exciting year ahead, and thank you very much for your support. More than happy to take questions. Thank you very much, Teresa. Any comments or questions? Billy, Claire, and Rhian.
Sorry if it's a silly question, but do we streamline our Welsh-speaking patients to Welsh-speaking clinicians where possible?
Nai atab yn Gymraeg os gael.
I'll answer that in Welsh if I may, because we are dealing with a Welsh language item. Do our best. There's a lot of work going on the wards to ensure that we are streamlined. And we've also got the active offer and the little orange badges. You might have seen them on the walls. Now these badges are in fact on the electronic boards within the wards as well. You'll see them on the electronic boards as you go into the various wards. So yes, we are trying to do that, in particular with older people, with mental health patients, and children, of course. They are our priorities. Of course, it's not always easy. Because after all, we don't always capture the information so that people can do that matching work. So it's a challenge. There is a lot of good work happening, but I think we can do better. I think we need to make it as easy as possible. Claire, and then Rhian.
Great report. It's really good to see. I think Betsy is quite an exemplar really around promotion and use of the Welsh language. And so two things. The only area I could see in the paper that identifies that we have more work to do is around internal meetings. So I don't really understand what the standard says about that. So it'd be helpful, Teresa, if we could understand that and know how we might address that or what we could do to address that. And then I think secondly, there's probably some really good learning for other organisations in North Wales. So housing associations, as an example, will need to meet the requirements of the Welsh language standards from the spring next year. And I think it would be really great for the journey that the health board's been on to be shared more broadly with other organisations across the region. I can perhaps pick that up with you separately outside. So.
Coming
back, I'll ask Rhian to Mike. Yes, well, I know this experience from my family, how important it is to have the opportunity to speak Welsh in your mother tongue across the range of services that we provide. Now, I just got a question really, in terms of how many members of staff who say they don't have any skills at all. That's almost 50%. I think it's 46% who say they have no skills. So is that across the various activities, or do we have a higher percentage in, doctors or consultants or whatever? Are the numbers dropping? Yeah, an analysis, is it? Is that what you're asking for? Yeah. Okay. Mike, Martha. Well, qualifications. I'm chair in Dwyfor, and we were one of the very few that did everything Welsh. We would, in fact, refuse to do anything in English. But anyway, that's by the by. The question that I've got, and see that there is real enthusiasm, but how can we ensure that we educate in a way that we don't rush in? I've been in various meetings, and people are asking me, what happened? Was that passed away? So, we need to be alive to that. We need to ensure that we don't speak too highly. We want to target people who are on the street and the workplace. Yeah, okay, that's a very valid point about plain Welsh. Yeah, again, looking at numbers, you know, I think it's important that we share what we have done. We have been very successful. You know, I think we need to thank you for the work that you're doing. But I think it's also important for us to look at the costs as well. You know, what costs are associated in funding the energy around these developments? I think it's important to look at the costs. Any comments on some of those points? Yeah, well, thank you very much. I'll start with Claire. Well, there is a regional group for more than just words, and I can put your team in contact with them. But we would love to come and talk to you about the journey that we're on and are still on. So thank you very much. Now, in terms of these standards themselves, health boards, you know, we are very different in Oxford. You know, we run this board bilingually. And we're very fortunate that we've got a translator here today. So we are able to run these board meetings naturally. And I'd like to thank you, Chair, for maintaining the bilingual element within the board. Now, there is an expectation on us to hold these internal meetings bilingually if possible. And of course, we are the only health board that are currently doing it as a board. Now, we've spoken with Pam about having some of our committee meetings bilingually as well, and we have given them a shot. But it's usually the clinical areas are where the standards kick in. Because the standards are a bit like bingo, going from 100 to 157, you've got different numbers. I'll ensure that I'll give you the correct wording about the expectation around internal meetings, but it's the wording that is important within the standards, because that's where the Commissioner picks up on. Rhian, you're quite right. You know, the patient outcome is so important. And if the work and treatment is provided in their mother tongue, then that treatment will be much better. Now, the information in the document is a self-assessment score, but you're quite right. We are seeing an improvement across the professions. I don't have those details in front of me, but I can dig them out. But what we are doing, of course, is to ensure that telephony and our receptionists, we do some targeting work when we look at essential roles and roles where Welsh language is public facing. Now, Mike, you're quite right in terms of tone of voice. You don't have to be an academic. I'm not an academic. I'm not as good a speaker as you, David, Chair. But, you know, I always give it a shot, and that's what's important. But in terms of our staff, we have a Welsh week, and we encourage people to use their Welsh, use whatever Welsh they've got. Yeah, use the little Welsh you've got. Bore da, pnawn da. Diolch. It's lovely to hear people giving it a go. And then our first question. Yeah, there is a cost associated, and, you know, health boards in general in North Wales have prioritised these costs. So we do have a team in place, but the requirements are now bigger than the team. But having said that, I think we are seeing the fruits of the labour in this report, and also in the work that is happening on our wards. You know, I'm sure that we can share some of that if possible. And can I also thank the team who have been so hard-working to ensure that this has been successful. The good news is that I've got even more of an ambition for us as a board. I believe that we can achieve so much more as a board. And in that respect, I'm keen for the Culture Committee perhaps should have an opportunity to discuss what do we want to achieve as a board with the Welsh language. Yes, we have to comply with Welsh language measures and standards, of course we must do that, but I believe it's time now for us to reflect as a board. You know, we've reached a point where we are now. Where do we want to go next? How will that future look in terms of the Welsh language and the use of the Welsh language within the health board itself. So I hope that the Values Committee will have a discussion about that soon. Thank you very much for all the work that is going on, and thanks for all the report and as well. Are you all happy for us to receive and approve the report? Thank you very much. So on we go now to the next report. The annual report for nursing, and I'll turn to Angela for this report.
So the report in front of you is the 3-yearly assurance report on compliance with nurse staffing levels as part of the Act. We received this report in its first stages in March with information up to the 31st of January, with the expectation that the extra information would be included, and then we submit it to Welsh Government in October. This is on a template developed by the All Wales Nurse Staffing Group, so we're obliged to use this template, and when we do our 6-monthly reviews again, we're obliged to use the template that's provided. It gives information around all of the improvements around Nurse Staffing Act. So with support of finance, since I've arrived, we are now compliant and meeting with the Nurse Staffing Act requirements, which is articulated within the report. Out with that, we're also working around the wards that are not part of the Nurse Staffing Act. So just recently, the finance team and the HR team have been supporting me to do the reviews for our emergency quadrant, our mental health learning disabilities division, and our community hospitals. And Russ and I have been meeting to discuss how we align where we are from a support and budgeting point of view, and the improvements that we actually need to make. So I'm happy to take any comments, but to note that it's just an add-on to what we've had previously.
Unrhyw sylw neu gwestiwn? Gareth?
It's a question.
Thank you very much for this report. Thank you particularly for highlighting where the changes have been. I was about to write a note when I was doing my notes saying, couldn't you just point out that I got to the bit where you said, yes, so thank you. That was really helpful. I mean, just to sort of like dog that just
heard you.
Yeah, dog that doesn't bark is I mean, I think it's really useful to have it, but I think it's section 25E about trying to see whether there's any link between patient harm incidents and this never starting. And basically it suggests there isn't, which at one level is positive. But another level, it shows that the challenges are more about, I mean, obviously sometimes there will always be some incidents, as we talked earlier, but it suggests that the issues are more about culture than number of people. So as I said, in a way that's encouraging, because the culture is something we're already really working on. But yeah, thank you for the report, and that it's ready to go now.
Billy?
Yeah, Doctor. I've got three points from the report, but looking at the data in these short reports, where planned rosters are not met and not appropriate, the mitigations always seem to be the same. We ask ward managers to work clinically. We ask staff to work extra hours and shifts, and of course bank usage. And yeah, I'm just concerned that we burn our staff out doing that. My second question is that we've just had the Welsh Government pay circular, and that doesn't mention bank. So the award won't be applied to bank unless we decide it's going to be. And I worry that bank will vote with their feet, especially where they have choices, and further challenge the nurse staffing levels. And finally, we are facing a cliff edge in nurse recruitment, recruitment and retention, and lots of nurses are going to be retiring soon. Applications for nurse training are tailing off. For me, there's certainly ethical implications in international recruitment. So we've got more challenges in the future to nurse staffing. What are we doing to encourage young people in North Wales to enter the profession?
Okay,
Angela?
no problem. So thanks for the questions, Bennett. From your first question around the planned rosters and the mitigations that we've put into place. So Band 7s, as you understand, are completely supernumerary within the health board, which is obviously really good practice and allows us to support the staff on the wards and do developments. We do utilise Band 7s coming into the numbers should we have short-term sickness and we have areas that have got increased security and we need to have that support. That is balanced with making sure that the matrons are supporting and the heads of nursing are supporting those areas and trying to release those Band 7s as soon as we possibly can to do that. I meet with the Band 7s on a monthly basis and have conversations around the amount of time they're spending clinically and what I can do to support and what we can do as an organisation to support. We have reduced our vacancies in the last probably 15 months from 14.5% to 8.5%. So we have seen an increase in substantive staff on those wards. So the opportunity for us to not have to use those Band 7s on a regular basis should actually be there. We're also utilising agency and bank in a much more effective way and doing planning around that. We've seen a reduction in our use of agency because we have got reduced vacancies and because we are planning on what the staffing models are going to be and completing our rosters in a more effective way. So we do have roster management meetings on a Wednesday morning with the heads, the directors of nursing and associates to look at what that compliance is. And now we've got a dashboard that actually went live last week where Carol can drill down into where our wards are applying their rosters and making sure that allocation of annual leave or study leave, etc., doesn't actually deplete the wards. So we're making sure that it's appropriately utilised. We do offer staff extra work if they've got vacancies, as well as applying bank. We do have substantive sort of bank staff who only work bank and don't work on the other wards, but the ward managers and the matrons are very clear to watch how much extra the staff on the wards are doing to support them not to be burnt out and that we maintain their health and well-being, and that is obviously some of the resources that HR provide to enable us to do that. So obviously it's something we're mindful of, but from I'm 37 years like Carol, and there has been agency use and bank use over that time, and we need to make sure that we are supporting people who need to do extra work as well because of financial climates and things like that. On the second one around the bank and the pay circular, there hasn't been an identification yet, but as Exec Director of Nursing and as the EDONS group, we will be highlighting that to NHS employers to identify whether that will be something that's taken into consideration. If not, as in previous rises that we've had around bank, we will take a paper to execs for discussion around that. We had one fairly recently, and that will be taken forward. So we don't want our bank staff to be disadvantaged and lose them because they are really, really supportive and delivery of our care. And we have a lot of staff who are utilising bank for flexibility. Said that, because of the increase within our vacancy opportunities now, we've got those less vacancies. We are encouraging our bank staff to become permanent with us, and we're actually asking agency staff to convert to bank and then move over to be permanent. And that's been really successful in the last 6 months. We've seen a number of areas. We don't actually use bank or agency anymore. We don't need to because we're fully staffed, which is an amazing position to be in currently in the current climate. And then from the perspective of nurse recruitment, so we are looking at opportunities of how we can make sure that we've got the nurses where they need to be. So we're looking at care around the bedside, so utilising multidisciplinary teams to look at that care delivery. And we've got a workforce planning team that are going to be joining us and supporting us to be able to do that, to identify the right patient at the bedside or within the community, providing the care where it's needed. I'm leading on the parameters of practice work for the nursing associates we're introducing in Wales. So that will enable us to do that wraparound care as well. We're also looking at school visits and work experience. So HR colleagues are supporting us going out to local schools and colleges to identify what opportunities there, not just for nursing, but for AHPs, for admin, clerical, finance, etc. And we do have a cadet scheme that has commenced looking at bringing students from 16 to 18-year-olds into the organisation and giving that succession to allow them to progress into nursing. We've got progression of healthcare support workers. So we've got band 4 support workers who are being sponsored to go on to do their nurse training. They live locally, they're committed to the health board, and they will come back and work for us. And then we're looking at graduate training as well. There are a number of universities offering graduates from different areas to come and top up to become a nurse. So I think although it does feel a little bit daunting going into it, I think we do have a number of opportunities. And if we can get the culture right and we can get where we need to be right, then we'll attract people to come and work with us and we'll be okay.
Great, diolch yn iawn. And it just struck me, Billy, I'm just checking, as our trade union representative and as our CN rep, are you plugged in to where you need to be to raise these questions and get information elsewhere? And if not, maybe, Angela, you can have a discussion with Billy to make sure that happens, not just at board meetings, but elsewhere, and make sure you have that engagement. I think that would be a positive thing to do.
That'd be helpful.
Great, diolch yn iawn. Pawb yn hapus i dderbyn yr adroddiad yna?
So you're all happy to receive that report? Mike?
Do we have, as an organisation, some kind of graphic or a projection of where there's going to be a drop off because of the demographic and age profile of staff?
Yeah.
Do we have future projections of where it's likely to dip?
I'm really hoping that all our workforce planning and what we discussed yesterday, I think in our discussions around planning and strategic look to the future, will be able to capture that. But also the People and Culture Committee, I think that's something they could look at, the future needs and the pipeline that serves it, and are they in sync, and what do we need to do? So hopefully that we'll be able to address that. Pawb yn hapus i dderbyn y adroddiad? Gwych iawn, diolch yn fawr iawn I bawb, a diolch am y gwaith yna.
Thank you very much, everybody. Thank you very much for the work. Next is the COVID report. So just an update really about the COVID investigation. I'll turn to Jane for this item. Thank you very much.
It's a joint.
Right, okay. Over to you then, Pam.
I'll kick off and then Jane might want to come in on the, because it links to the next item, David, as well. So this paper is the paper's hopefully is self-explanatory, but it gives an update to the board in terms of the recommendations that have been published from the Module 1 inquiry, which are covered in the report. I suppose we've also tried to give an update of as other progress in terms of other modules into the inquiry, so we can make sure the board is fully cited. As you'll appreciate, it's a moving beast, and Glesney in my team plays a very active role in managing not just this, but we heard about the Thirlwall inquiry earlier, and there's been some work in terms of the infected blood. So there's a lot of public inquiries where we need to distill the recommendations, opportunities for learning, and how we can reflect those in the health board. So you'll probably get a sense there's quite a piece of work around distilling some of that. So in terms of this report, it aligns back to our annual delivery plan, where the commitments that we would take on board in terms of any learning lessons and actions we needed to take as a health board. Obviously in section 4 of the report details the findings and from the published report in terms of module 1. What Leslie and Sharon in Jane's team have done, they've mapped the sort of recommendations to what we call the current health board state and potential future requirements. I think it's just important to recognise some of this. There will be a national piece of work, because obviously this is not just local health board, it's at a Wales and a UK wide basis. So there will be some national groups and national frameworks or information or recommendations that are likely to be coming out to health organisations. But this report is that we're starting to look at what the recommendations are, starting to make sure where we need to make local actions and local changes, we're building those into our plans. It should give the board a level of assurance just in terms of how we're dealing with some of those. And I think Jane will probably come on perhaps in the next paper around the work in terms of it's, you know, emergency preparedness, resilience and response, just in case it rolls off the tongue, in terms of some of the work that is going on across the organisation and it's through the PPE committee. I think the last thing just really to say, David, we've taken this through our executive team. We've agreed to set up a steering group which will start to look at not just this inquiry but other inquiries. We'll need to have a wide membership in terms of that group and draw people in as necessary. So it's an active piece of work, ongoing piece of work. Just wanted to bring this to the board to give them the opportunity for sightedness, and I think I'll probably take it through your committee, Claire, just in terms of regular updates on progress. Yeah, I didn't know whether you wanted to add anything
on COVID inquiry work in particular before we go to the next item.
So this is module 1, so it was about the preparedness. So a lot of the headlines were about how government was not prepared for this. The implications of this, though, do apply to us as a health board because it will have some significant changes to what is expected in terms of being prepared for future events and the degree of oversight that we will need to put around that sort of civil contingencies. So we will be working with the national around what that means in terms of the standards and what is expected as a health board that we will be needed to deliver. We are also looking, and this is from the health protection as well as an EPR, what everybody is saying is the next pandemic will not look like the last one, which didn't look like the last one. So it is about that planning for how do you manage a significant outbreak at a population level. So there will be a separate piece of work which is really looking at how do we get a single outbreak and highly contagious infectious disease plan that we can monitor, because what we have already seen in post-COVID, we've had COVID, we've had Mpox, we've had measles, and we've had a couple of other things, all of which show that actually we need a core plan that can be enacted against any of these, and that people do know what to do, because each time the evidence has been we've had to relearn things. So all of this will be being built in as part of this, and there's going to be a lot more learning to come from future models, but this one really focuses much more around the emergency planning that we're going to need to do.
Great. Diolch yn iawn. Unrhyw cwestiwn? Mike.
Any questions? Mike.
In other kind of forums, but is it a default kind of position that when we're designing, particularly new buildings, that this is taken into consideration, whether it's with flows in and out of the building, but the practicality of a building that might potentially need?
Yeah, I'm just keen that we concentrate on the COVID report first before going on to the emergency preparedness, resilience, EPPR, and that is an issue which I'll ask you to address afterwards. But on the COVID, any questions, please? Gareth, within that.
Well, just a comment, which is about I'm glad in a way you've addressed it, but I think it is sensible to have the steering group, but you will need to be flexible in the membership because it'll cover quite a wide range of different things, won't it? But the question was just, I noticed that module 3, which is probably the one that's most directly relevant to NHS bodies, so it's what happened in these areas of treatment during COVID, is now underway. And I noticed they only seem to be taking evidence in London, and like with the previous where they moved around. So has there been any request for input from this health board or Welsh health boards in general about these issues, or are we off the hook, if I can put it that way, in terms of giving evidence?
Before you respond, I'll bring Ursula in any other question, and then I'll ask Pam and Carol to respond.
Thank you. Obviously, this report confirms lots of discussion that we've all heard in the media about the preparedness and perhaps lack of honesty as well going on in certain quarters. And I know that module 6, module 7, they're going to be happening quite a way down the line. So I'm just wondering what the timescale is to feel that we would have our systems in place if an emergency did happen. When would, we have an idea of what this timescales might look like? Whether might be ready to, yes, it would be 2026 if an emergency happened, we can respond. Just a question. I'd like to do something.
Any responses, Pam and Carol? Any?
I'm happy to pick up. So module 3 is
Yes.
underway. I know that colleagues from Wales have been to London, and so that will take a Wales look as well, not specifically, but and we did submit a information into module 3 as well. Just as a footnote, module 10 has now been announced, which is going to look at the impact on society. So that's quite good. I'm not quite sure.
Yes.
But we'll get to that one. I think Eartha's question about are we ready for an emergency really comes into, this is why we've linked civil contingencies and this, because we can get all sorts of emergencies. And I recall very early on in the pandemic, before we really knew it was a pandemic, about whether this was a rising tide civil emergency or what lane it would be in. Ultimately, we need to think about any emergency, national power outage, floods, all of those sorts of things, as well as infection.
Diolch yn iawn. Felly, nawn ni at y droddiad nesaf mewn munud, ond ydym ni'n hapus I nodi...
So we'll turn to the next report in a second, but are we happy just to note this paper and the recommendations from module 1? And also to note that the steering group has been established as a health board to continue this work. So we're all happy with that recommendation. Thank you very much. So we'll move on to the next item, which talks about the EPPR, or EPRR, in fact.
And you've talked a little bit about this already, Jane, but if you want to add anything else, and some people have already raised questions around it, so if you could address those at the same time, that would be great. Diolch.
So I'm not going to go through the project, it's fairly clear. What I will say is this is a work in progress. So we do have plans. We have and we do have business continuity and civil contingency. So all of those. What there are is issues about how up to date those plans are and how much they reflect the sort of current understanding of what we would need to deliver as a health board. And that sort of slightly answers Eartha's, because one of the things is we are not going to wait to 2026 when some of these things. So we are already using some of the best practice, such as the standards that England uses around assessing itself against its plans, because they are much more detailed and much more specific than the Welsh ones. And we are already planning on the learning from some of these things about making sure we're ahead of the curve in terms of the things we know we need to be prepared for better. That's come out of not just this, but some of our looking at where we are with partners in North Wales, also planning for the environment in North Wales in terms of the possible things that could happen given the nature of the industry and other elements that we have within the North Wales environment. And that also leads to the final point I want to make. What we are also looking at is how we actually work better with our partners around that civil contingency. And actually, there was another final point I'll forget, which is the other thing that we probably have not been good at is testing and exercising.
Yeah.
And that links to the partners, because actually, so one of the first things we're doing is on call is to make sure everybody has had some basic on call training.
Yeah.
That actually means that everybody is clear about what they should be doing at bronze, silver and gold level. Partly because my view is that nobody should be doing on call unless they've had some basic training.
Absolutely. No, and the matter that Mike raised, preparedness of the estate, if I could describe it like that, is our estate in a condition.
So one of the things we are looking at is things like evacuation and isolation, partly because of a couple of issues we've had around infectious diseases, actually.
Yes.
So all of those are all part of this, and but we're having to do this in a sort of staged way. So because there's quite a lot of work across the board, so we are trying to pick out the things we need to do first, and then sort of get a line of sort of planned work over the next 18 months or so.
Just a very brief one on the estate, and I think we need to think very, very differently. So the whole climate change issue, extreme weather, adapting our buildings to what the future is going to look like. So I think that's in that lane as well, in terms of preparing for hotter periods and how we wetter, how we adapt to that.
Great.
Floodings.
Yes.
Right, Carbon Apples, either been
okay, so I'm happy to receive that report. Thank you very much for the very important work that is taking place. I think that annual report gives us a snapshot of the work that is happening. So everybody happy? Thank you very much. So I'll go to the next report, which is the corporate governance report. And I turn to you, Pam, for this report.
I'll take the report as read. Just a couple of approvals from the board today to ratify the chair's action on the 13th of September, which we agreed to do because that's a matter reserved for the board in terms of the legal procedures in relation to emerts. Other matters are for information other than to ratify joint committee governance arrangement. So that is included in a separate pack. And hopefully that's helpful. It has been through we had the board, remember, I think it was probably March meeting, we had the initial documentation. Work has been ongoing in relation to that. It's been through the joint commissioning committee, which Carol is a member, earlier this month. So just asking the board to ratify the governance documentation. That becomes part of the health board standing orders. So what we will do is, following the ratification, we will update our standing orders so they become as part of. And then finally is just to ratify the approved commissions, doctors, as we're required to do. And again, that's included in the supporting pack. Happy to take any questions.
Diolch yn fawr iawn, Pam. Unrhyw gwestiwn?
Thank you very much, Pam. Any questions? No. So everybody's happy to confirm and to ratify.
Also ratify the Joint Commissioning Committee governance.
We have no option to change anyway.
And ratify the commission's section and doctors across Wales, and that's the role we play for all Wales, of course, in that. Pawb yn hapus i wneud hynny?
So everybody happy to do that? Yes, thank you very much. Thank you very much again for that work. That brings us to the for information section, and we have reports from committee chairs. There are a list of them there for information only, but of course if anyone has any questions, then I'm going to give you an opportunity now. Any questions? No? If not, then thank you very much to all the committees for their work. You can have a taste of all the work that is happening in those papers. There is a lot of significant and detailed work taking place. So thank you very much to everyone who's involved with that very important work. Then closing issues. We are coming to the end of the meeting. And one item that we always try and cover is the meeting effectiveness. Does anyone have any thoughts or comments on meeting effectiveness?
And how we can improve things in particular. certainly point out things that aren't good, but also if we can think of the future and how we can improve our meetings as well. Claire, you've got some thoughts.
I wanted to thank Pam and the team. I think there's been quite a lot of change in these papers today to reflect feedback from the board. So I think it was great to have some of the clunky information as a separate pack for us to review separately. I think the recommendations in the papers are much clearer now. So I think we're moving really positively forward in terms of the quality of the papers. So thanks for your leadership, Pam, but to everybody else who's obviously responding well to that. If I had one thing I'd ask, it'd be that the meeting didn't need to last 5.5 hours, Chair.
Yeah.
But we have a lot of business to get through, and it's hard to give the items the time they deserve and make the meeting much shorter, really.
Yeah.
Other than meeting every month, but I think I'd rather have every 2 months than a longer meeting.
Yeah, no, good point. And the litmus test for me will always be: are we spending the time on the items that we need to? Obviously, everything deserves our attention, but there are some things that we really need to ensure we're spending time on. So that's a good test. Gareth?
Yeah, I just echo that, but also say I think that the order of the papers, I mean, with no disrespect to things like EPR, which are really important, but they're effectively telling us what is and isn't working so that we know.
Yes.
But I think generally the orders work much better, that we've actually had the time that we needed for the things that we needed to give real input on. So, I agree.
And I think we're developing a series of discussions around key areas, aren't we? We've had planned care, we've had urgent and emergency care today, and I think those discussions have gone well from what I've seen. But you may have some thoughts as well, Billy. Bring in at the end.
I know that we've had board meetings in the West. We've had quite a few board meetings here. We ever had board meetings in the East?
I think in the past that has been the case. What we're trying to do is, for board meetings, we're trying to identify this place, this venue, as the ideal place for a whole host of reasons, mainly around the technology and our ability to broadcast and get all the tech correct and the type of room. At the same time, we are holding meetings across the health board area, for instance, as Mike referred to the one in Mouldy the other week. So we're not too concerned the fact that we have to move the formal board meeting around from one area to the next. We're more concerned about getting in a good place where everything works for us, quite frankly. And Linus is with us. Linus and others did, and Diane did a huge search about 12 months ago to look for appropriate venues, and there's a shortage that can take us all as well, and appropriate space. So we're more concerned about the right venue to get the meeting running successfully, but we use other meetings to reach out to communities and engagement events in particular. So yeah. Unrhyw arall efo rhywbeth I ddeud before just
does anyone else have anything else to add?
We'll have some comments, I'm sure. As someone who's been in the heart of getting all this running like clockwork, and Diane and the team and Linus and Philippa and others, and Laura, really grateful for all the efforts putting this together. It's always, we always seem to be really fighting to get things done around the meeting, and really grateful for everybody's efforts. And Diane has gone more than the extra mile. Diolch o galon I ti, Diane, am fynd yr ail a'r dryder.
Diane for going the second and even the third mile.
Thoughts about helping us in the future with the meetings?
Just really, I suppose, thanks to the board, thanks to everyone for giving us really helpful comments as we go on this journey. As I say to Gareth, we're on the journey. Just reflecting, it's my third board meeting. I might feel like it's.
She's not one of the 14% who leave.
No,
Yeah.
Don't
But
worry.
I suppose it's just really, I thought it's always good to just check in where we are, and I think having there's a good chunk of time focusing some on big strategic issues today. So I felt that we gave that the time it deserved. I'm starting to see a really good flow between the board and committees. So we get the item and then scheduled care, for example, now take that back through the committee. So I think that feels
and flow in the other direction as well.
Yeah, so I think we're I think hopefully going back to Claire's point, really great. We've got a minute left and we will have bang on time. So great to try, David. And I just really want to say thanks to the team actually, because what people might not always realise, the preparation, getting us to this is actually really quite hard. But actually, if you try to just do a bit of work on the timing of the agenda, so I think that's worked well. So I just wanted to share those observations and thanks to the team that did the hard work for us.
Diolch yn fawr iawn. Unrhyw arall rhywbeth sy'n dweud?
Anyone else? Any other comments?
Na. Gai ddiolch.
No? Well, if not, can I thank you very much for your contributions in this meeting today. Thank you very much to everyone who's been involved in the preparatory work, as usual. Does anyone have any final comments about board meetings? Well, of course, you're welcome to get in touch with us at any time, especially if you feel that we need to develop anything further. We welcome any positive comments anytime. I'd now like to confirm the next meeting, which is the 28th of November in 2 months' time. And we now go into private session. So therefore, I propose that we exclude the press and the public in accordance with Section 1 of the Public Bodies Act 1960. So we now move into a private session due to the confidential nature of the business being discussed. Do you all agree that we move into private session?